Hello, everyone. My name is Nitin Ahuja. I'm an assistant professor at the University of Pennsylvania, where I'm also co-director of the program in neurogastroenterology and motility. I'll be talking to you today just briefly about how to prepare for seeing your doctor. I guess the first question to address is why is preparation important? You might think that um, medical history is the sort of thing that you know like the back of your hand. Likewise, you might think that doctors are good at what they do and have the right questions to ask to guide you towards an appropriate pathway through diagnosis and treatment. I think the reasons why preparation is a good idea are a few. One is that time is often limited, and that's time both in the context of the length of an individual appointment, which can be as short as 10 or 15 minutes, just depending on how clinic templates are designed, and also the time between appointments. So, for instance, in my practice, my usual follow up interval is anywhere from 3 to 6 months. Which is kind of a long time from one face-to-face visit to the next. And so using that time efficiently or as efficiently as you can, I think serves you and the provider well. A second reason is that without preparation, diagnostic effort may be wasted. So if an endoscopic procedure report is not immediately available, a clinician may just deem it easier to repeat that procedure rather than looking at prior records, interpreting that information, integrating it into their assessment, and then thinking about a new step forward. So preparing can be helpful for avoiding reinventing the wheel. And then at the end of the day, you're the best person to tell your story. I often tell patients that I'm meeting them for 30 to 60 minutes out of their lives, but they're with their bodies 24/7. So knowing your medical history and preparing for a visit is a way for you to take control of your narrative, and ideally position a clinician as a partner in your care. I think a good goal is to aim for a clinical story that's accurate, coherent, and comprehensive. In terms of the elements that go into preparing for a clinic visit, I think there are a few worth emphasizing. One is to just at baseline know your story. Again, that may seem intuitive, but there are a few elements of a story that can become so familiar that they're hard to describe to other people who you're meeting for the first time. So I think often in terms of timelines. Other clinicians may be different, but I think a timeline of symptoms is really important. A long course of illness can sometimes be difficult to parse out historically. But using phrases like "it all started when" or "things got worse when" can really be helpful to help determine a timeline and to communicate that to a clinician. For instance, I think it's a big difference between someone who's been constipated their whole lives and someone who's been constipated for a month or two. So again, that detail is salient. Um, I think with regard to language, it's also the case that, particularly with gastrointestinal symptoms, our language tends toward the vague. And so, if your own symptomatic descriptions feel vague to you, you might practice ahead of time in describing them in a more specific way. For instance, a phrase like "upset stomach" carries some information, but not as much information as a more specific phrase like "cramping, pain in my upper abdomen" that occurs for about an hour after I eat. A thorough clinical history will get to that more nuanced that more nuanced description eventually. But if you can provide that description up front, it's all to the better, and again provides more time to discuss the implications of those symptoms. I think it's important to know your current medications both by name and by dosage. I think it's also important to emphasize the fact that includes over the counter drugs, herbs, supplements, probiotics that you may be taking. Clinicians aren't always the best at asking for that information. So if you can provide it up front, obviously that has bearing on your care. And then knowing what's already been done to evaluate this problem. That includes blood work, imaging tests, endoscopic procedures, including the biopsy results if that's relevant, and then any other specialized testing. I don't think you need to know the results by memory, but knowing what's been done is helpful, as well as to know where to look for the results of those tests. I think it's also important to know what's already been done to treat your problem. This is particularly relevant for doctors whom you're seeing for a second or a third opinion, or if you've been referred by a primary doctor to a specialist, or from a specialist to a subspecialist. So knowing what's already been done, particularly with regard to medications, includes knowing what's been prescribed, what's been taken, recognizing that those two categories aren't always the same, at what dosages those medications were taking, recognizing that medications are often titrated up or down depending on a patient's response to them, if the medication helped, and then the reason why it was stopped. Was it unhelpful? Was it associated with side effects? That kind of detail can be relevant, again, to know what ground has been covered and what opportunities are open for the future in terms of treatment. The image on this slide is taken directly from one of my note templates for patients with gastroparesis. I'll usually set aside some time to go through a whole list of potential medications and interventions for a given diagnosis for patients who've seen other doctors before me, just to know what ground they've covered before and where I might make a difference. But my asking those questions is contingent on a patient knowing the answers to those questions. So it's important to know what you've tried in the past. And then by the same token, it's important to know, I think, what hasn't been done. So medications that either have been discussed by clinicians or researched on your own, but not yet tried. And then any testing that's been discussed, but not yet performed for whatever reason. I think that's important to know and to bring up, to set an agenda if you have one for a clinic visit. Moving on to the question of records and what you might need to bring to a visit, I'm sensitive to the fact that it can be an intimidating prospect to introduce yourself to a clinician with a stack of hundreds of pages of records. But my own view is that if you're in doubt, you should bring them, and erring on the side of more information rather than less doesn't hurt. It's also sometimes the case that patients presume that records are in the system if they've been requested ahead of time or if they've been performed at that health system. I think it's still worth your while to bring a hard copy of especially salient records in those circumstances for a few different reasons. One is that records do get lost, unfortunately, and sometimes they're hidden in various pockets of our increasingly Byzantine electronic health records. Records are often sent and received between practices by non-clinicians, so very diligent administrative staff, but who may not have the clinical background necessary to know what records are important or where there are obvious gaps. And it's also true that some clinicians don't review records ahead of time. And so if questions come up that could be answered by records in the context of your clinical interview, it can be helpful for you to have a piece of paper with the answer on it rather than have the clinician dig in the chart and get distracted by a tangent. I do think there are some distinctions in records between those that are more important and less important. Obviously, this is painting with a broad brush, and so I don't want to say this applies to everyone. But in general, I think the records with objective findings on them are more critical. So procedure reports, pathology reports, imaging reports, laboratory values. Again, you may not have the results of those records memorized. So having those records on hand to communicate to a clinician can be really helpful. Relatively speaking, I think less important are progress notes or nursing notes from hospital stays. Those tend to carry less information, relatively speaking, though discharge summaries from a hospital stay can be very helpful in my mind. Patient instructions that you might get that have sort of boilerplate language on them relative to your discharge diagnosis, I think that's helpful potentially for patients, but less helpful for clinicians. So just to summarize, I think preparing for a medical visit can entail a fair bit of time and energy, but otherwise I don't see a big downside in over preparing. Even if some tests get repeated or if some of the pages you bring to the clinician's visit go unreviewed, knowledge is power. And at the end of the day, just knowing more about your illness is going to serve you well. And I'll say I'm sensitive also to the fact that some clinical stories are confusing by nature. Um, when you're seeing another doctor because your prior doctor hasn't helped you, or there seems to be more to still unpack, it's not the fault of the patient. It's not the fault of a storyteller that the confusion is there, but those stories still, and maybe even in particular, benefit from imposing a logical framework on them through again knowledge of your history and an adequate basis of record. And so, the sooner you get to that logical framework, the sooner you and your provider can move forward, hopefully, towards some clinical progress. So I'll stop there. Thanks very much.